Ladies and gentlemen,
This is the Dunlop podcast, brought to you by Keating Dental Arts, a full-service, award-winning dental laboratory. Each week, you'll learn tips and techniques from real-world dentists, bringing you in-depth interviews, motivating stories, current events, and sports.
Here is your special host, the Senior Technical Advisor for Keating Dental Arts, Brandon Fetters.
Hey everyone, Brandon here. Welcome to another episode of the Dunlop podcast. Our guest this week studied anthropology and conducted research on burning mouth syndrome at UCLA School of Dentistry. He later attended Harvard Dental School and won numerous clinical and research awards. These awards led him to research trends in postgraduate dental education, which was published in the prestigious Journal of Prosthodontics in 2007. Currently practicing from Fresno, California, please welcome Dr. Ryan Dunlop, DMD. How's it going, Dr. Dunlop?
It's going great. How are you doing today?
Doing excellent, thank you. Well, Dr. Dunlop, I really appreciate you taking time out of your busy schedule to meet with us on the podcast today. So let's go ahead and jump right into it. Why did you get into dentistry? At what point in your life did you decide to really go for this profession?
I would have to say that I was probably a teenager in orthodontic treatment myself, and I had a really good relationship with my orthodontist and his staff, and I really admired the kind of work that he did. And so I remember my mom telling me that when I got to college, I might want to look at, being a dentist and being an orthodontist like mine. And so that's kind of what I did when I got to UCLA. I started off as pre-med or pre-dental and kind of worked my way through the different science classes and realized about halfway through college that dentistry was definitely the right choice for me. My wife was going to go into medicine, and I saw what that culture was going to be like, and I just didn't see myself there. I really wanted to be an entrepreneur and have my own business. So I saw dentistry as the perfect mixture between entrepreneurship and being able to provide healthcare.
Yeah.
So when I got to dental school, I realized that dentistry was a good fit for me, but I didn't enjoy orthodontics the way I thought I would. I went to school with the thought that I would be an orthodontist, and that didn't pan out because I poked myself with wires too many times and realized that I wasn't a wire bender, and I wanted to do more surgical implant-related stuff. That was really my passion. So I started on that pretty early and decided to forego an oral surgery residency or perio residency because I really wanted to provide the full spectrum of care to my patients. So it was an interesting path that I took, but I'm happy with the result.
Awesome. Yeah, no, where exactly did you attend school?
I went to Harvard Dental School. I graduated in 2006. It was a really good experience. It's a very small school, very personalized curriculum. I spent 2 years in Harvard Medical School mixed with the medical students, so that was very, very, enhanced in education there. And after that, I did 2 years of a GPR in New York City at the Bronx VA. That was a really good program for me. But the extra education was really fundamental to developing my clinical skills. Harvard did a good job teaching clinical dentistry, but it wasn't the focus all the time. There was a lot of other stuff going on in terms of research and institutional learning and stuff like that. So I felt like the GPR was really required if I was going to deliver a high quality general practice dentistry.
Absolutely. Now you mentioned the dental surgery. What's your favorite procedure in dentistry?
About 80% of my time is spent placing and restoring dental implants. So I'm a sedation dentist, so I provide my own IV sedation services. So the most rewarding cases for me are the full mouth extraction and implant reconstructions. They're really life-changing for people. I enjoy all phases of dentistry, but I definitely gravitate towards the surgical implant reconstruction cases.
Yeah, excellent. Now, when it comes to implants, do you have a certain system that you prefer to use?
I've cycled through probably 8 to 10 systems in my career. I've never found a system that I felt was ideal for every situation. Some implants are good for immediate load procedures, but not very good for molars, and some are good for denture, overdenture cases, and some are good for immediate extraction cases. I've never really found one implant that works in every case because I just don't think that's possible.
Yeah.
So I've really gone through a bunch of them. I currently use 3 or 4 systems in my office just based on my experience and what works well. So I don't really have a favorite.
Gotcha. Yeah, you can't have that one size fits all. Everything's custom in dentistry, so that's a very good point.
Yeah, it doesn't work that way. Every mouth is different. Every site is different. I have 2 or 3 systems that I think work in most cases, but I think it's very problematic for young dentists when they want to settle on a system and just go with that one, because you're really pigeonholing yourself. There's a lot of great products out there, a lot of great companies, and if you just limit yourself to working with one, I think you're cutting off your nose to spite your face.
Yeah, no doubt. Along those lines, do you have any advice you would give to new dentists coming into the profession?
I get asked that a lot because I run a very large, successful surgical GP practice. I get asked all kinds of questions about how I built it and how I get so many new patient referrals and how I get so many quote unquote big cases.
Mm-hmm.
It's simple. It's not rocket science. You focus on quality, and that is the bottom line. There are lots of quick tricks. There are lots of loopholes to get through. There's lots of marketing companies that will sell you, a bridge over, somewhere. But the bottom line is, if you're not providing the highest quality dentistry that you possibly can, none of it matters, because word of mouth is much, much more powerful than any marketing campaign. And even though I do spend a lot of money on marketing every month, it pales in comparison to the goodwill that I've created through the quality dentistry that I provide. So I tell young dentists all the time, don't think about business CE courses. Don't think about institutes where they're teaching high-level stuff. Don't think about marketing. Don't think about taking out loans to pay, tens of thousands or, hundreds of thousands of dollars in technology and consulting until you are providing high-quality dentistry. And that takes a while to really figure out. If you can't capture a crown margin, you can't fill an endo appropriately, if you can't do fillings quickly and easily, if you can't make a nervous patient calm, if you can't provide a really good experience for your patients, then you don't need to be worrying about the other stuff. You need to worry about your diagnosis, your treatment planning, your execution of the treatment plan, and the quality of your care. That is paramount.
Yeah, that's excellent. Yeah, it's kind of got to have that true foundation before you can start building up the other aspects.
Absolutely. And when people ask me, how do I do a full arch reconstruction in one day? An implant reconstruction with immediate load and send people home smiling, whereas before they were not. Well, then I say, show me your work where you did a quadrant dentistry, 3 MODs and a crown. Were you able to deliver all of that care and have it be, very high level care? If you can't do that type of work, if you can't fill a molar endo, to the apex, if you can't do simple stuff extremely well, how do you expect to be able to handle something with so many variables and so much unpredictability as a full arch implant reconstruction?
Yeah, certainly. When you mentioned that about the immediate loads, I assume that you're using CADCAM and CT scanning. Is that correct?
Yeah. Over the years, I'm more or less 10 or 12 years into my experience with full arch cases, and I've gone through everything from dentures to chairside conversions to staged approaches and sinus grafting and zygoma implants. This is an evolving field, and I'm to the point where I rely very heavily on technology and equipment to provide same-day reconstructions. And the technology has become a fundamental part of my treatment planning and my case execution, but it only matters because I understand where it came from and what the limitations of it are and what the strengths of it are, having done everything else. So it becomes a tremendous tool when you understand how it came to be from a fundamental level.
Now, I just can't help but wonder, do you speak at conventions or gatherings?
Not really, because I've done that. I did that earlier in my career. And I find it difficult to connect with people and convey this type of information in large groups. I personally have never been to a lecture that changed my life. Most of the time I feel that large venues and large lectures are just opportunities for the lecturer to show off their best cases and to kind of talk about things in the abstract, but rarely do they give a look behind the curtain. So I prefer to teach. I do help other doctors and lab technicians and other people in the industry, but I tend to want to provide that to smaller groups, less than 10 people, just because I just feel like I can't connect and convey the passion that I put into my career when it's a large group.
Yeah, it's a very, very good point. It's like having that private lesson versus those large classrooms. No one ever really.
Yeah, I have people come to my office and do kind of like mini residencies and over the shoulder and stuff like that. And I've mentored a few doctors across the country, just by them coming out here and spending a week and seeing what I do. It's much more effective than trying to convince a room full of 800 people that you figured it out.
Absolutely. So when it comes to maintaining your CE credits, what do you tend to do for those?
Most of the time, I'm not a big CE, hound. I know there are a lot of doctors that preach taking a ton of CE, and I understand the importance of it. But whenever I look or seek out CE opportunities, I always try to choose things that teach me how to improve my bottom line, because it's fun to take a CE course on something abstract or something that is out of your field, but you're never going to bring that home and put it into play. It's just going to go on the shelf like everything else. If it's a procedure that you think you want to do, or if it's a system that you're looking to employ, if you can get CE out of that training for that, then you've killed two birds with one stone. You've improved your workflow or your technique, but you've also gotten CE out of it. So I'm a big advocate of taking CE that actually matters instead of, kind of just taking it like a shot in the dark and hoping that you get something out of it. I'm too busy to sit and listen to, someone talk about something that doesn't pertain to my daily life.
Absolutely. Now, have you ever thought about potentially going back and to like a professor type role to teach other doctors?
It's not on my radar right now. I live in Fresno, and there's no dental school in Fresno. If I were, further down in my career and there was this opportunity to it, I would like that. I do enjoy helping out young dentists. Right now, basically, I have people who contact me online through social media all the time asking me for advice, and I just answer the questions as best as I can. But if the opportunity ever presented itself and I could be in, kind of a mentoring role or an education role, I wouldn't turn it down.
Now, obviously, you have quite a bit of technology, like you had mentioned in your office. What's the latest piece of equipment that you have in your practice?
That's a good question. So I recently purchased the PIC dental system, which is a digital implant capture system. The term for the technology is photogrammetry, and it's been around for a while, but it's getting more and more popular as the technology for full arch reconstructions is getting more advanced. I'm really excited. I really enjoy using this technology because in the past, one of the hardest things to get correct on a full arch case was the passive fit. So you would work very hard to get the aesthetics right and to get the occlusion right, but then when you went to deliver your final prosthetic, which you put a lot of time and energy and money into, it didn't fit perfectly. And you had to make a choice. Well, am I just going to crank this thing down and hope for the best? Or am I going to redo it and find out where it went wrong?
Yeah.
And, I've done both. And, there's pros and cons to both. Sometimes the patients just want to get their teeth and get out. They don't want to go through the whole process again. Sometimes the dentist doesn't want to go through the whole process again of remaking everything. And then sometimes I've remade cases that didn't fit perfectly. And at the end, they didn't fit perfectly again. And so I invested in this technology that allows us to take a perfect implant impression from the time of surgery, which is humongous because you've digitalized that patient's case from day one. So you can deliver very high quality, very precise fitting temporary or final prosthetics in a very short amount of time. That doesn't mean you have to go faster on the case. You can stretch the case out for a month and let the patient heal and adjust and make changes. But because you've got it in their case in a digital file, a modifiable digital file, you're not stuck with what they have in their mouth. I've had cases that I've changed 5 or 6 times over the last couple of months because of patient or my preference. And it's so easy. You go back to the digital file, you move the teeth around, you 3D print another try-in, and you see how it looks. In the past, you'd have to reset denture teeth and have the patient in for long visits. Now they tell us over the phone what they want to try differently. We just tweak it on our computer software, 3D print another try-in, and have them in the next day. It's very convenient and predictable, and the outcomes are better, and the patients are happier.
So with these same-day deliveries, are you using any zirconia restorations to do that, or what type of product are you using for that?
Well, zirconia takes a lot of time to manufacture, so I don't see that as a feasible option for same-day procedures. Plus, I'm not sure I would want something that's so hard I can't adjust it easily in the mouth. So the majority of my same-day conversions are with the PIC system. We do a printed take-home temporary that's designed to only last, they last for a while, but we only want them to last for a few days to a few weeks. That gives my technicians time to work with some of the more rigid materials. So the patient basically goes home with a 3D printed temporary that's designed to break if it's chewed on too heavily. And a few days later, we have them back for what we call a long-term temporary. Could be a finished product. You could have a zirconia full arch reconstruction done a few days after their surgery if you wanted to. That's not my preference, but I know people who have done that. But what I choose to do is to have them in a mill framework with a long-term temporary material like PFMs. That can be delivered a few days after surgery, and then they're pretty much on cruise control. It's a perfect fit because of the digital impression. You've already adjusted the occlusion because that was done at time of surgery. So the long-term temporaries look as good, if not better, than the finals I'm used to delivering. Then we have them back after a few months, and we make final adjustments and write down any changes, any issues they might be having, and we go back to the digital file and we fine-tune it and we tweak it where we need to. If we need to have them in for a final try-in, that's simple. But most of the time, people are very happy with their long-term temporaries, and we just basically copy them into the final zirconia or metal-based, whatever restoration you want to do. But it's very predictable.
Excellent. Do you, out of curiosity, are you using PFMs at all still?
No, I haven't put a PFM in the mouth in at least 5 years. I get just as good, if not better, results with all of my ceramic materials. I mill in-house, so I have a wet-dry milling unit here and a full-service lab. So I can experiment with whatever materials I want. And I have just found great success rates with full zirconia crowns, bridges. If I need a more translucent material, we switch to Emax or lithium disilicate materials.
Yes.
Between those, and I haven't found an issue with anything. So I think those two materials by themselves can cover the vast majority of cases.
Okay. That makes sense. Well, Dr. Dunlop, thank you so much for being on this week's episode of the Dental Up podcast and for sharing your story on how you built up your practice. And not only that, but also helping our younger dentists understand the limitations of dental technology and that the rest really depends on their initial fundamental knowledge of the procedure that they're doing. And for our listeners that want to follow up with you, look below at our show notes, and there you will have the contacts for your social media as well as your website. Well, Dr. Dunlop, thank you again for being on the podcast. If you have any questions or need anything, please let us know. Hope you have a wonderful weekend.
Oh, you're very welcome. Thank you.
Thanks for joining us on the Dental Up Podcast Show this week. Make sure to follow us on Facebook, Instagram, and Twitter, or search the Dental Up Podcast on iTunes for our weekly feed. Don't forget to visit KeatingDentalArts.com/promo for exclusive offers. Keating Dental Arts is a full-service dental laboratory, and we're nationwide. We'd love for you to send us a case so we can show you the Keating difference. If you dig what you heard, please leave a review on iTunes, and we'll be back next week.